Hi, my name is Major Sarah Beth Hershey, and I'm presenting Pain, Anxiety, and Delirium. In this presentation, we'll be going over background, team-based multimodal approach, prevention, evaluation, treatment, medication dosing, complications, and AE considerations. At the end, there will be a post-test. Pain is universally present in combat casualties. Ensuring that critically injured patients are treated for PAD is an essential in the acute setting, but also for prevention of the potential long-term consequences when they are not addressed appropriately. Beginning with point of injury and continuing through the increasing echelons of care, active management of PAD encompassing prevention, assessment, and treatment are medically and morally imperative. Sometimes surgical and life-sustaining treatment priorities may conflict, take precedent, or overshadow the assessment and active management of PAD. Adequately early pain control to reduce post-traumatic stress disorder and ongoing pain control is an obligatory part of trauma care. The stress response involves a well-established sequence of physiologic and molecular events that include fever, tachycardia, tachypnea, hypertension, gastrointestinal ileus, hypercoagulability, protein catabolism, and immunosuppression, among other undesirable consequences that delay or prevent a wounded warrior's full rehabilitation and recovery. Effective pain management requires coordination of all medical providers from the point of injury through the echelons of care and the medical evacuation system. Pain is frequently accompanied by anxiety and delirium in critically injured patients, and the medications utilized to treat these conditions may paradoxically prolong or even exacerbate them. A multimodal approach to pain control can reduce the total dosage and duration of narcotics required, minimize or even eliminate complications associated with narcotics, and reduce narcotic dependence. Adjuncts such as acetaminophen, ketamine, NSAIDs, continuous peripheral nerve infusions, and continuous epidural infusions greatly increase patient safety and the effectiveness of narcotics while reducing the side effects. The adoption of a team-based multimodal approach to the management of pain, anxiety, and delirium most feasibly commences at the level of Role 3 care and should be continued throughout the Role 4 and subsequent CONUS care. This multimodal management includes the establishment of an acute pain service starting at the Role 3 and continuing for the duration of the casualty's care. The APS is staffed with existing combat support hospitals assets and should include a physician, pain consultant, chief nurse, and ward pain nurse champions. The APS personnel should interact directly and frequently with the primary testing service. This is best accomplished by including the APS in daily rounds. The APS is responsible for daily rounds, pain management consults, and reports to the trauma team leader. The primary mission of the APS is the provision of effective pain control as well as the treatment and prevention of anxiety and delirium in an injured patient. There are standardized and validated scoring systems for the assessment of PAD. The DVPRS should be used to assess pain, the RAS score should be used to assess anxiety, and the CAM should be used to assess the presence of delirium. APS should consist of an interdisciplinary team of physicians, nurses, and pharmacists and should be available 24/7. They should be responsible for coordinating pain management with the validating flight surgeon and medical evacuation team in the receiving MTF. Pain as a product of trauma cannot be prevented, but there are many mechanisms for minimizing and managing pain. This begins with interrupting the mechanism and treating the injury. An essential part of long-term pain control is early and adequate intervention at the point of injury. Pain recognition and assessment should be a routine part of combat casualty management followed by prompt intervention. Early interventions are essential to prevent the psychological and biochemical consequences of pain and pain-related phenomenon and to reduce the risk of chronic pain syndrome. Orders for the treatment of pain and anxiety should include Set goals and the minimum amount of medication necessary to achieve the goals should be used. The goals are determined by the need to achieve patient comfort and safety. Patient and delirium begin with recognition. All combat casualties are at risk for anxiety, which they may attempt to conceal or not disclose. Management of the underlying etiology, including pain, hypoxia, metabolic abnormalities, and medications effects are essential principles. Disorientation to place and time as a result of unconsciousness, sedation, and loss of awareness that results from hospitalization contribute to PAD. This can be prevented with frequent and systemic efforts at reorientation and maintenance of normal sleep patterns. Interventions to promote healthy REM sleep include exposure to bright light or sunlight during normal daytime hours and enforced darkness during normal nighttime hours. Intermittent dosing of analgesics and anxiolytics should be instituted prior to continuous dosing. Patients who require dosing more frequently than every 2 hours should be placed on continuous dosing titrated to their goal. Efforts to prevent delirium in critically injured patients include awakening and breathing coordination, non-pharmacologic delirium interventions, and early exercise and mobility. The ABCDEs should be incorporated into treatment care plans for all ICU patients starting no later than the Rule 3. Spontaneous breathing trials should be performed daily. Physical and occupational therapy should be initiated as soon as possible and no longer than 72 hours after intubation. There is sufficient evidence that prophylactic administration of antipsychotics prevents delirium. We make no recommendation for it. Benzos, although potentially useful to control agitation, may increase delirium and should be avoided or minimized in patients experiencing or at increased risk for delirium. Level of pain is present in all combat casualties. Seriously injured patients who are not intubated should be assessed every 1 to 4 hours for the presence of pain. All patients who are intubated need to be continuously monitored for adequate analgesia. Signs of inadequate pain control in the intubated patient include tachycardia, hypertension, and agitation. It is imperative that other causes be excluded, such as early compartment syndrome, missed injuries, or impeding physiologic decline. Use the DoD VA Pain Rating Scale and supplemental questionnaires as qualifiers that can facilitate evaluation and trends. In the AE system, we use the 0 to 10 numeric pain rating scale, Wong-Baker Faces, the DVPRS, and the FLAC scale. This is the DoD VA Pain Rating Scale. Also the DVPRS. Anxiety, agitation, delirium, as well as pain can be complicated by the presence of a TBI. Therapeutic interventions can affect the evaluation for agitation as well as impede an accurate neurologic assessment. Moderate to severe TBI patients are particularly high risk for having atypical and/or paradoxical reactions to both sedating and stimulating agents. The reactions to individual agents and their overall impact on the TBI patient in terms of pain, alertness, agitation, anxiety, and delirium may change drastically over relatively short periods of time as their injury and cognitive status evolves. The Richmond Agitation Sedation Scale and the Confusion Assessment Method tools help with the evaluation. This is the Richmond Agitation Sedation Score. This is the Confusion Assessment Method. In order for the patient to have delirium, the patient has to have an onset of changes or fluctuations in the course of the mental status and inattention, as well as either disorganized thinking or altered level of consciousness. As previously stated, pain is a universal symptom of the combat injured patient and must be managed early and effectively. Any opioid available can be titrated to equal effectiveness for achieving desired pain control. Casualties should be disarmed after being given OTFC and always disarmed after receiving ketamine. Documentation of a mental status exam using the AVPU method should be performed prior to and after administering opioids or ketamine and recorded on the TCCC card. Analgesia on the battlefield should generally be achieved using one of three options per the TCCC analgesia protocol. This is an abbreviated presentation of that protocol. Control surgery is provided at Role 2. In the more austere Role 2, pain should be managed with intravenous opioids and ketamine titrated as needed to provide adequate pain control. If dysphoric symptoms emerge with ketamine, then a small amount of benzos should be administered. More robust Role 2s will have additional personnel, equipment, and supplies available. At these locations, the capability might exist for peripheral nerve blocks, which could be performed by the anesthesia provider or by the orthopedic surgeon assigned to the unit. Infusion pumps may also be available for continuous opioid infusions in critically injured patients, with doses titrated as needed to provide adequate pain control. Patients on infusions require close monitoring in an ICU setting. Be adequately controlled prior to starting a patient-controlled analgesia. The approved PCA for flight is the ambit pump. Patients on PCA requiring monitoring by nursing staff. Narcan must be available to treat respiratory distress that may occur secondary to opioids. Considerations for the PCA pump. In addition to correct labeling of IV and pain medication containers and bags, ensure all IV and pain management tubing is taped labeled with drug location, date, time, and Zulu. Ensure PCA pump is locked after setup, dose change, and turnover. At each patient care handoff or change of shift, make sure to assess pain score, vital signs, pulse ox, and mass baseline score every 2 hours to treat pain as needed. Assess for side effects. Assess tubing and bag every 2 hours. Verify pump infusion history and current configuration with sending receiving nurse or MTF representative, and annotate remaining fluid on the front of the AF Form 3899A or EHR equivalent. 2 medical personnel will clear the pump every handoff and change of shift. Ensure to confirm the order. If unresponsive to painful stimuli or respirations are less than 10, stop PCA and refer to the AE clinical protocol narcotic or benzo overdose. Regional anesthesia procedures should be performed in a monitored setting where nursing staff is available to help with patient care and provide appropriate recovery services for the patients. The Acute Pain Service, APS, should maintain and provide input for standing orders to include continuous epidural and peripheral nerve catheter infusion, single injection epidural and intrathecal narcotics, and intravenous patient-controlled analgesia orders. Fentanyl, hydromorphone, and morphine are the narcotic agents of choice. Demerol is not an approved compound for repeated PCA dosing. Low-dose ketamine infusions have profound analgesic effects with very minimal side effects. The anti-inflammatory effects of ketamine may also attenuate the systematic inflammatory response seen in trauma. Ketamine binds the NMDA receptor, and in addition to having direct analgesic properties, it also decreases the total dose of narcotics that is needed for pain control. See slide for dosage. Epidural catheters. Neuraxial analgesia can be very effective pain treatment in the injured warfighter, but special care must be taken to ensure that it is provided safely. Standard preservative-free local anesthetics include ropivacaine and bupivacaine. The standard medication for AE is 0.2% ropivacaine with sufficient volume for 3 days. While all antiplatelet and anticoagulant medications increase the risk of bleeding, low molecular weight heparin use in patients undergoing epidural anesthesia greatly increases the risk of epidural hematomas, which can lead to paralysis. No narcotics will be added to the peripheral nerve block or epidural infusions given the ongoing revision of validation for air transport. See slide for epidural dosing. Peripheral nerve catheters. All catheters should undergo a local anesthetic test dose containing epinephrine. For patients undergoing deep plexus or peripheral block, the JPCPG ID29 recommends recommendations regarding neuraxial techniques be similarly applied. Each patient should have no more than 2 catheters, and the total dose of ropivacaine should not exceed 20 mL per hour. Regional anesthesia patients should be recovered by standard PACU criteria. AE considerations for epidurals and peripheral nerve blocks. An epidural analgesia or a peripheral nerve block infusion must be in place and running without incident for a minimum of 4 hours prior to departing the facility. More dilute solutions will be used to decrease the risk of sympathetic blockade. All infusions must be stable at an analgesic level, not a surgical level. The patient should be able to regain partial motor control of the lower extremities. All must be used with an approved infusion pump and must clearly be labeled. High alert 2-person double check required and documented on AF Form 3899M or EHR equivalent. Ensure to assess pain status, mass sedation score, dermatome level of analgesia, vital signs, motor function, and drug side effects every 2 hours and at patient handoff. Assess the dressing for leakage every 4 hours and record on the AF Form 3899N or EHR equivalent. Catheters will not be removed by AECMs. Given the nature of combat injuries in the environment of care, both agitation and anxiety can be expected and should be preemptively managed. In a patient with normal hemodynamics, propofol is a good option for short-term sedation. Propofol does not provide analgesia. It is the most commonly used medication when sedation is required for ICU patients and CCAT transports due to its rapid onset and clearance. Propofol can cause hypotension and should be used with caution in patients with intravascular depletion. It is an excellent drug choice for ICU patients scheduled to undergo AE. Propofol should only be administered to patients who have a definitive airway, are hemodynamically stable, and are continuously monitored by trained personnel. Precedex is being used with increasing frequency in ICU patients and occasionally for transport. It minimally decreases respiration, so it can be used for patients on non-invasive mechanical ventilation or sedation for awake intubation. It has some mild analgesic effects. It should be used with caution in patients with bradycardia or heart block. It has minimal impact on respiratory drive and allows for ongoing assessment of the patient's mental status. Clonidine is an effective drug for treating patients with anxiety and agitation. It's particularly effective for patients with hypertension associated with agitation. It may also be used for mild sedation and analgesia. The typical antipsychotic Haldol and the atypical antipsychotic Seroquel are commonly used for the treatment of delirium. Seroquel is particularly effective when used at night as needed to help regulate sleep in a patient at risk for anxiety and delirium. Both these drugs can be associated with a prolongation of the QT interval, potentially resulting in fatal arrhythmias. The QT interval should be monitored with EKG on a daily basis. Medications should be specifically directed and dosed to achieve a defined goal. For example, achieve a pain score of 4 or less, maintain sufficient patient consciousness to assess the evolution of injuries by physical exam, decrease the need for mechanical ventilation, or decrease symptoms of anxiety, delirium, or agitation. Intermittent dosing, as opposed to continuous dosing, has been shown to reduce the duration of mechanical ventilation, and intermittent dosing should be instituted prior to continuous dosing. Although many sedative agents are utilized for their short duration of action, administration of continuous infusion would often result in a prolonged duration of action and effect due to fat storage and accumulation of active metabolites. It is recommended that intermittent sedation should be used whenever feasible. For patients who require dosing more frequently than every 1 to 2 hours, continuous dosing titrated to effect can be used. However, continuous infusion should be converted to intermittent dosing as soon as possible. Daily interruptions of sedation or sedation vacations have repeatedly demonstrated reduction in the duration of mechanical ventilation as well as the incidence of ventilator-associated pneumonia. Intermittent dosing and daily sedation holidays prevent the accumulation of active metabolites, which may impede patient assessment for prolonged periods of time. Continuous infusion should be stopped daily to obtain a reliable physical exam, including neuroassessment, and to perform a spontaneous breathing trial in ventilated patients. Sedation goals should be assessed every day following sedation holidays, and every effort should be made to reduce infusion dosages. Contraindications include intractable intracranial hypertension, hemodynamic instability, and the inability to adequately oxygenate or ventilate mechanically ventilated patients. Local anesthetic toxicity, or LAST, is rare but possible. Symptoms include cardiac arrest, seizures, tinnitus, anxiety, restlessness, dizziness, and blurred vision. If at all suspected, stop the infusion immediately. In cardiac arrest, start the intralipid bolus and continuous infusion. Ensure intralipids should accompany patients receiving local anesthetic infusions during transport in the AE system. If in the AE system and LAST is suspected, initiate the AECP local anesthetic toxicity protocol and notify the validating flight surgeon in C2 as soon as possible. Nausea is a common side effect of both trauma and the medications used to treat pain, anxiety, and delirium. Consider prophylactic treatment whenever possible and treat immediately upon patient report of symptoms. If the patient has recently undergone an emergency general anesthetic or any type of abdominal surgery, then ensure that they are not at risk for aspiration. If there is a concern for gastric distension or any type of obstruction, the patient should receive gastric decompression with an NG tube in addition to pharmacologic management for nausea. Zofran is a safe antiemetic in the adult population and is increasingly the therapy of choice for acute, undifferentiated, and trauma-related nausea. It has no effect on consciousness or the respiratory drive. In addition, dosages recommended for these patients, 4 to 8 milligrams per dose, has no clinically significant effect on the QT interval. Compartment syndrome is a well-described complication of traumatic injury. Definitive treatment is complete surgical release of the extremity compartments affected. Pain control may mask the typical early signs of compartment syndrome, increased pain in the compartment. If there is any concern for compartment syndrome, then full compartment release with fasciotomies must be completed prior to AE transportation. The patient movement request must state the type of regional anesthesia being utilized. All equipment associated with the use of the regional anesthesia must be approved for flight. The current infusion pump system that has been approved for the U.S. Air Force AE is a small portable ambit pump. Ambit pumps should be used for epidural, peripheral nerve catheters, ketamine infusions, narcotic infusions, and PCAs. In terms of peripheral nerve blocks or epidural catheters, no narcotics will be added to infusions. The addition of narcotics to these regional therapies changed the validation for air transport by the U.S. Air Force. Stresses of flight for a patient in the AE system with pain include decreased partial pressure that can exacerbate O2 deficiencies due to pre-existing hypoxias related to injury, disease, or treatment. This also may exacerbate CNS effects of pain medications. Barometric pressure changes cause gas expansion in the abdominal cavity that may exacerbate pain and the risk of hypoxia. Consider placing an NG tube. Cold temperatures may lead to vasoconstriction, shivering, and exacerbated pain. Keep warm and limit exposure to cold temps. Vibration and turbulence may increase muscle activity, metabolic rate, and peripheral vasoconstriction. Assist with position changes, provide adequate padding and skincare, and place away from the bulkhead and floor. Make sure to use padding between seatbelt and abdominal injuries due to gravitational forces. Fatigue can exacerbate underlying conditions and diagnoses. According to the AFI 48307 Vol 1, to manage pain, obtain vital signs every 4 hours for patients who require en route pain medication administration. Make sure to always rule out hypoxia and consider compartment syndrome prior to treating pain. Determine the characteristics of the pain: quality, region, radiation, what provokes or triggers it, what eases it or palliates it, and what's the adequacy of and adverse effects of pain medications. If there's a pain score of 3 or more, usually indicates the need for pain medication. Pain and vital signs will be reassessed 15 to 30 minutes after interventions. Non-drug interventions to assist alleviating pain include maintain body alignment, elevate extremities, change position, readjust splints, and encourage physical activity. Please review this slide for a complete summary of what was just covered in this presentation. Here are your post-test questions. Number 1. In the ABCDEs of delirium prevention, what does the C stand for? Number 2. What reduces post-traumatic stress disorder and is an obligatory part of trauma care? Number 3. What all should be labeled when caring for a patient with a PCA in the AE system? Number 4. What should accompany a patient receiving local anesthetic infusions during transport in the AE system? And number 5. True or false? If a peripheral nerve block has malfunction, turn off the pump and remove the catheter. This presentation was derived strictly from the Joint Trauma System Clinical Practice Guideline ID 29 and AFI 48307 Vol 1.